This conference will now be recorded.
So good afternoon, everybody. Today's dermatology class is on cutaneous drug eruptions. So as we prescribe many drugs, not just in dermatology, but the knowledge of this topic is useful for you in your the medicine, surgery, or anywhere. Since we prescribe drugs in every department, so this gives you a generalized knowledge, and I think it will be quite useful for you. So try to pay attention. So as we give many drugs, and we all of us know drugs have certain kind of adverse effects. So now we are referring to the dermatological adverse effects of these drugs. So this is a common consequence and seen around in 5% of the population who are taking these multiple drugs. And what's fascinating about this is the spectrum of the disease is quite wide, like starting from rashes to the life-threatening, or in fact even death. So that much wide range is there. And coming to the pathogenesis, there are only two possibilities. It should be either immunological drug reaction or non-immunological drug reactions. And coming to the immunological drug reactions, and this is the Coombs and Gell's classification. I'm sure all of you know this. You might have come across this in your second year itself. And there are 4 types, as you know, drug reactions. The type 1 is anaphylaxis, or you can say IgE dependent reaction. Example is urticaria. And type 2 is cytotoxic reaction, and example purpura. And type 3 is due to immune complexes deposition. You see that in vasculitis. And type 4 is cell-mediated type of hypersensitivity, as you see in contact dermatitis. And coming to the non-immunological reactions of the drugs. One is the pharmacological adverse effects. Like in chemotherapeutic drugs, there will be hair loss. And also the second is the accumulation type. Due to accumulation of the drug, you will see argyria with excessive silver intake. And some drugs, they change in the natural ecological balance of our body, like use of broad spectrum antibiotics. When there is use of these drugs, there will be change in the vaginal flora, leading to acute vaginal candidiasis. And there are idiosyncratic means unique to a person. And ampicillin induced rash in infectious mononucleosis is an example. And next, as you know, drug overdose. Increased dosage of anticoagulants may lead to purpura. And sometimes there will be intolerance due to altered metabolism. See, any drug, once it comes into our body, it always has a certain pattern of metabolism, how it gets excreted and everything. Sometimes if there is any alteration in this whole metabolism pattern, what will happen, there will be accumulation, or sometimes the excretion will be delayed. So like that, then we will, like for example is isoniazid induced lupus erythematosus. And Jarvis eczema reaction is a very important reaction. Specifically, we see in syphilis. See, in syphilis, we treat syphilis with penicillins. So once we give penicillin injection, what will happen? There will be destruction of the syphilitic organism. And once it gets destroyed, what will it do? It will release all these toxins and antigens into the into our body. So that will lead to an acute reaction, which is the Zaritz hexamer reaction. And always drug reactions, you need a complete history. History is very important, especially in our geographical region, where there will be many RMPs and all. So what do people tend to do in rural areas? They first go to an RMP because I don't know, maybe they are easily approachable than us doctors. So that is the reason they take this multiple drugs, which maybe sometimes neighbors will also prescribe. So always history. History is very important. We have to review the complete medication list, including the over-the-counter medicines, and also document prior history of any adverse reaction to food or drugs. And also we should inquire about viral infections or any metabolic disorders or their immune deficiency status and everything. And also we should note all the prescriptions and also interval between the drug introduction and the onset of the rash. So this is very important. So sometimes we see cutaneous eruptions within few hours also. Sometimes it might take weeks. So depending on that also, we diagnose the reaction. So that is important. And next, the route of administration, the dose, duration, frequency, and also past history, and also how soon the drug was withdrawn, and also any improvement after the drug withdrawal. So improvement post the drug withdrawal indicates strong, like it's a strong indication to the drug reaction. And also clinical examination, we have to look for signs of any severe drug reaction. So always we have to keep this in mind. Any life threatening cutaneous drug eruption starts as a normal rash. So always we have to examine the patient completely, and we should look for the signs that this might go into severe drug reaction. Like that, we have to look for those signs, which is very important. First sign is mucous membrane involvement and blisters on the body, Nikolsky's sign. All this we should be very careful when you see all these things. And also angioedema, that is swelling of the lips, swelling of the eyes, also breathlessness, and also palpable and non-palpable purpura, and skin necrosis, and also high fever, dyspnea, and all the signs of sepsis. And see, there is classic drug reaction patterns, and some reactions, they mimic other dermatological conditions. So these are two different entities. So today we are going to talk about classic reactions and the reactions which mimic other dermatological diseases. So that is what we are going to discuss today. And always we have to analyze the pattern of the drug reaction, because it will help us in determining the causative medicine, defining the appropriate therapy, and also we will be able to tell the prognosis. Now first is the fixed drug eruption. Here circular violaceous edematous plaques with erythematous border are seen, and these resolve with hyperpigmentation. And also these lesions usually occur in same area whenever the offending drug is given. So once a patient comes to you with a fixed drug eruption, and we can ask them about the past history. They have similar lesions. They will tell yes. And what's unique about this reaction is usually it will occur in the same area, like history of recurrence of lesions in the same area every time they take the drug. That is the uniqueness of fixed drug eruption. Yes, someone wants to say something. Hello. Okay. And now common sites. Common sites where you'll see the FTE lesions are hands, feet, mouth, and genitalia. And also drugs which cause are as acetaminophen, anticonvulsants, NSAIDs, piroxicam, cetirizine, ciprofloxacin. Ciprofloxacin is like very common, and clarithromycin, and also sulfonamides, dapsone, tetracyclines, and metronidazole. So these are the drugs which usually cause FTE. So this is a picture of FTE. See, you'll see well-defined lesion is violaceous and the border is erythematous. So here the same kind of lesion you will see over the lip. And next is erythema multiforme. And erythema multiforme has two forms. One is minor form, the other is major form. So minor form, typical targetoid papules will be present, in the acrally over the limbs, over the lower and upper limbs. That is a minor form. Whereas coming to the major form, similar lesions with one or more mucous membrane involvement, but the epidermal detachment will be less than 10% of body surface area. And also lesions are distributed centripetally, that is trunk and the proximal part of the limbs. See, targetoid lesion is a classic lesion of erythema multiforme. That means when you might have seen the darts game, right? Where you throw a dart and it will hit a target. That will have like rings, like different colored rings will be present. So that is what we called as targetoid lesions. So there will be rings like lesions with different colors. Those rings will have different colors. And SJS TEN is also a part of erythema multiforme, which is now discussed as a different entity. So what are the causes of erythema multiforme? First, most common is infections like recurrent herpes simplex infections, mycoplasma, HIV, or cytomegalovirus or hepatitis B. And drugs like penicillins, quinolones, tetracyclines, anticonvulsant and NSAIDs and rifampicin, these kind of drugs are very common. And other causes are lupus erythematosus, polyarthritis nodosa, sarcoidosis, also pregnancy, any vaccinations and malignancies. Here lesions are mostly either macules or papules, and they evolve into classic, like I told you, targetoid lesions. And the target lesion, classical lesion, will have the central zone of dusky erythema or purpura, and the middle zone will be pale because of edema, and the outer ring of erythema will be present, and it's a well defined lesion. And there is something called atypical targets, like instead of these 3 zones you will only see 2 zones. So then the lesion is called as atypical target. And these lesions are mostly seen on palms and soles, dorsum of the hands, and extensor aspects of limbs and face. And also post-inflammatory hyperpigmentation will be seen once the lesions get healed. So this is a picture, like you see in the hand of this person. See, there are rings like lesions will be present. I hope you can appreciate. And mucous membrane blistering is seen in 25% of cases. Usually mild blistering is seen, and eye involvement also is seen in only 10% of the cases. They will see bilateral purulent conjunctivitis with increased lacrimation. So this is the oral involvement, like you see, blisters and erosion in the oral cavity. And this is the eye involvement, see, conjunctivitis and increased lacrimation. Now coming to the most serious entities, life-threatening entities of these drug reactions, that is SJS and TEN. So SJS is Stevens-Johnson syndrome and TEN is toxic epidermal necrolysis. These are variants of a single entity, and they're characterized by the widespread blistering and completely effacement of the skin. The skin will literally get peeled from the body, like sheets of skin will get peeled, just like you remove skin over the vegetables, like that skin will get peeled off. So that is what you see in both these conditions. If it involves only like 10 to 30% of the body surface, you call it SJS, and more than 30% of the body surface is involved, then we call it TEN. So mortality is only 5% in SJS, whereas coming to TEN, it is 30% because it's a much more severe condition. And coming to the SJS, there is generalized involvement, blistering, and epidermal detachment. There will be fever, malaise, joint pains, and other systemic symptoms. Coming to the TN, they are also similar to SJS only, the lesions are, but this is much more severe, much more area of the body skin effacement is seen, and also hemorrhagic and vesiculobullous lesions will be seen, and also facial edema will be present. See, in SJS, the mucous membrane involvement is relatively more than in TEN. More than 2 mucous membranes will be affected in SJS. See, this is a picture. As you can see, the blisters, and you can see the patient. There is a peeling of the skin is seen in this patient, and also look at this his face. So everything is effacement of the skin. The skin is literally getting peeled off. Look at his forehead. Observe his forehead. So then you can understand what the peeling of skin is. Usually starts as blisters and then it gets progresses into like this. And we call it SJS only when there are minimum 2 mucous membranes involved. And the lips are crusted, bloody, swollen. There will be increased salivation, difficulty in eating because eating and even drinking water or even opening mouth because there are a lot of ulcers. And also difficulty in breathing with the tracheobronchial involvement. There will be edema might be present, and also dysuria because usually the urethral mucosa will also be involved. And also eye involvement is almost in 85% of the cases where you'll see eye pain, discharge, edema, synechia formation, and also ulceration in severe cases. Now, what drugs are causing this? Coming to SJS, usually anticonvulsant, phenytoin, NSAIDs, antibiotics like ciprofloxacin, and also greasephulvin, penicillins, rifampicin, all these. And also we have phenothiazine or furosemide, and also TN. Coming to TN, also similar drugs, anticonvulsant, phenytoin, and all these NSAIDs are very common in drug reactions. You will almost come across them in all these conditions. And also one more in TN, more you will see isoniazid also, and also sulfonamide tetracyclines. And I would like to add another group of drug, that is the retroviral drugs. You see all these nevirapine. Nevirapine is also like very common in drug reactions. And also anti-tubercular drugs also can cause this. Sometimes even a simple ranitidine also can cause SJS. So, but usually the antibiotics, anticonvulsants, and painkillers, these are the more common drugs, and also antiretroviral drugs. And there is another entity called as DRUS, or drug hypersensitivity syndrome. This is also potentially life-threatening, where you'll see fever, sore throat, skin rash, lymphadenopathy, hepatitis, nephritis, and leukocytosis, along with eosinophilia. This is most common with aromatic anticonvulsants, and usually begins within 1 to 3 weeks of taking the drug, but can happen sometimes even 3 months later also. And also drugs like phenobarbital, phenytoin, carbamazepine, dapsone, minocycline, NSAIDs, amitriptyline, allopurinol, all this can cause drug hypersensitivity syndrome. So actually we saw quite a few cases in ashram also, this drug hypersensitivity and eosinophilia. Next, coming to the serum sickness. It's a type 2 hypersensitivity reaction where you'll see erythema on sides of fingers, hands, toes, and progress to widespread eruption. And also there will be fever, arthralgia, arthritis, which is common. The drugs are beta-lactam, cefaclor, and minocycline, and sulfonamides, and NSAIDs. Now coming to the morphological patterns. These are drugs which mimic other dermatological conditions. Now first is the acneiform eruption. So drugs which cause acne-like lesions. These are, but the thing is, these lesions are monomorphic. That is either papules or pustules, and localized primarily to the upper body. And see how you will differentiate this from acne means pathognomic lesion of acne is a comedone. That comedone won't be present. Also acne, you will not see only one kind of lesion. You can say comedone, pustule, papule, all this. It's a group of different kinds of lesions are seen in acne. But whereas in acneiform eruption, there's only one morphological type of lesion will be present. So that's how we differentiate. And usually This is a picture of acneiform eruptions. See, the lesions look like acne, but they're not acne. And usually those with steroids, either oral or topical steroids, these are the biggest culprits of acneiform eruption. Next is lichenoid, means lichen planus like lesions. Here mucosal involvement won't be present, and there is scaling and eczematous lesions are seen. They look similar to lichen planus, but they are very itchy. See, this is the picture. You can see violaceous papules, well-defined violaceous papules present, just like in lichen planus. But the thing is, lichen planus will have oral involvement also. That won't be seen here. And also, this also photo exposed areas of the body will normally have lichenoid eruption. So that's how we differentiate. We can even take a biopsy that will help us in differentiating. And also next is erythema nodosum, another important condition very commonly seen. Here tender red subcutaneous nodules will be present over the anterior aspect of the legs. This is more commonly seen in females than males, and the lesion, they do not separate or ulcerate. Only the um, red erythematous nodules will be present, that's it. And they heal with post-inflammatory hyperpigmentation. The lesions are quite tender. So like this in the picture, you can see slight erythematous swellings you can see over the lower leg. These are very tender. And also there will be increase in temperature over the lesions compared to the surrounding skin. And also next, vasculitis. Vasculitis is a common severe drug eruption, and here blanching erythematous macules followed by palpable purpura is seen. They will also have systemic features like fever, myalgia, and abdominal pain. And also laboratory evaluation to rule out systemic involvement is very important. Whenever you see a vasculitis case, the workup is you have to do a thorough workup, because sometimes they might have systemic involvement also. So this is a picture of vasculitis. As you can see, the lesions you see are small. You can see palpable purpuric lesions, and petechiae can also be seen. And next, coming to urticaria type of lesions. So certain drugs will cause urticaria type of lesions, where you will see edematous erythematous wheals that may coalesce, and lesions appear shortly after starting of therapy. Usually the patient comes to you and tells you only after taking certain drugs he started developing this. And sometimes they may even develop angioedema. Angioedema means swelling of the lips, swelling of the eyes. That is what we call as. Sometimes, rarely, swelling of, edema of the airways can be seen. And next is drug-induced urticaria picture. You can see here. See, all these wheals kind of lesions are seen over his back. Okay, so next is morbilliform eruption or the exanthema. And most common form of drug eruption is this exanthematous rash. And here you will see symmetric, confluent erythematous macules and papules both, and usually starts after 2 weeks of therapy. Simple macules and papules, red lesions will be present, that's it. This is the most commonest of all. And this is how even SJS and TEN will start. Initially as an erythematous lesions, slowly they'll develop into blisters, and then you will see effacement of skin. So, and also mucus involvement. That's how it will progress. And next, coming to erythroderma. See, any condition involving 90% of the body surface area, we call it erythroderma. There will be scaling and redness present, and it will be associated with the systemic complaints like fever, intolerance to cold and all. and also lymphadenopathy. All these will be present. And we have to rule out all other conditions. We have to do all the routine blood tests. You see, to see if there is any other systemic complaints in the patient. See, this is a picture of erythroderma. Sheets of redness and scaling. The erythematous, the entire body is red, and there is sheets of scales present. This is a typical picture of erythroderma. And also edema is also present. You can see his hands, they are little puffy. So what causes erythroderma is there are so many other drugs and also other dermatological conditions also cause erythroderma. And see here, I listed out a few causative common drugs for all these eruptions. I'll tell you the most common things for you. Acne form, like I told you, corticosteroids, also hormones. See, those taking OC pills and all, isoniazid and also phenytoin. And these are the most common acne form lesions causing drugs. Coming to the lichenoid, there is amlodipine, also anti-malarials and beta blockers, all these drugs. And erythema nodosum also, oral contraceptives, halogens, penicillin, sulfonamides, and tetracyclines. These can cause erythema nodosum. And vasculitis. So drugs causing vasculitis are allopurinol, NSAIDs, cimetidine, and minocycline, penicillins, tetracyclines. These are most common. Coming to urticaria, AC inhibitors can cause urticaria, NSAIDs, and also cephalosporins. Again, ranitidine, penicillin, and some vaccines. Post-vaccination also you can see urticaria. And next, coming to the morbilliform rash, AC inhibitors and the amoxicillin, anticonvulsants, isoniazid, NSAIDs, and sulfonamides and quinolones. So these can cause morbilliform rash. And coming to erythroderma, anticonvulsants, cefoxitin, and chloroquine and chlorpromazine, all this can cause erythroderma. So as you can, after going through all these drugs, I am sure you might have heard few drugs repeatedly. So we have to be very careful when prescribing those drugs. Also, when the patient comes to you like with complaints after taking the drugs also, that's when you have to become alert and look for the any you have to examine, take a thorough history and look for what conditions a patient is having, like only rash, or if the patient is developing blisters. That's when you have to be very careful. And so be careful with all the NSAIDs, antibiotics like penicillins, convulsants, all these drugs. And next, coming to the differential diagnosis. See, drug rash will can mimic any skin disease. We can get confused with many diseases. Only some classic like fixed drug eruption and these targeted lesions, they are the classic of drug rash. Rest all, they can look like any skin condition. And the possibility of drug rash must always be kept in mind whenever you see a atypical rash. And also you have to exclude common skin conditions like all these fungal, scabies, and all these infections. You have to exclude. And also any underlying disease, if there is any SLE and all, you have to get them investigated. And also mild drug reactions can be diagnosed based on clinical symptoms and signs alone. Our complete blood picture, serum analysis to rule out any liver or renal derangements. We have to check. So that is why renal function test and also liver function test, all this should be done. And especially in this TEN and hypersensitive syndromes, getting blood investigations done is very important. Also, immunoserological tests may be also be required to rule out connective tissue diseases. And urine and stool analysis may be required in the case of vasculitis. And coming to other tests, there is a re-challenge test by means of skin prick and patch testing to confirm the causative agent, which can be done, but its value is very limited. Means the results are not consistent. So that is why they are not that useful. And also skin test may be potentially hazardous to those with the severe reactions. We cannot take any risk with them. And skin biopsy is very helpful to differentiate between diseases and their drug-induced counterparts in many conditions. Like I told you, in lichen planus or lichen or drug reaction, to differentiate between these two, it's better to take a biopsy. Also, drug withdrawal, single most important approach, may be difficult if patient is on many drugs. Then to find out which one is the culprit is always very difficult. And knowledge of drugs and its specific reaction and also morphology helps in accurate drug withdrawal. Now coming to the adjuvant therapy. Strict observation for mucosal and skin sloughing and antihistamines are all that are required in mild, mild like exanthemus rash and all. These are enough. And in SJS-TN and hypersensitivity syndrome, these three conditions compulsorily we have to get the patient hospitalized. Supportive skin care and fluid electrolyte balance should be corrected, and temperature regulation, all these are very important, because when there is skin effacement in the large part of the body, what will happen, the patient's like the thermoregulation gets interrupted. So it's always very important to maintain the body temperature of the patient. And ophthalmic consultation, because like I told you, there might be pulmonary conjunctivitis, increased lacrimation, synechiae formation, or even ulceration. So to avoid all those life-threatening condition, like life-threatening things, we have to uh, we have to consult an ophthalmologist for opinion, and thorough measures should be taken. That way we can preserve the eyes. And coming to the systemic steroids, though controversial, they can be used, and we use it also. And there is a mounting evidence for intravenous immunoglobulin use in TEN. The wound swab for bacteria culture sensitivity from skin or mucosal erosions should be taken. That way we can prescribe the right antibiotics. And systemic antibiotics is not required all the time. Only if there is any signs of sepsis and all, then only we prescribe them. And see, the conclusion is to this whole chapter is a warning against polypharmacy. Using too many things at a time, it should be avoided. Only those very much required, only those only we have to prescribe. So we shouldn't be overzealous and give too many drugs to a patient at a time. And if you suspect a drug reaction, keep going back to history, and also watch for eruptions when you start new drugs. So you have to educate the patient also when you are giving new drugs. And if drug reaction is noted, a thorough explanation and issuing a drug reaction card is also mandatory. This is very important. Half of the times what will happen, this is what is going wrong at the RMs. They will give some penicillin injections or something, some painkiller injections, and the patient comes to us with a reaction. And see, the patient never knows. He doesn't even know what kind of drug he was given. So that how can the patient avoid that drug in the future if he doesn't even know which drug it is? The same way, even us, we are also helpless if we don't know what kind of drug was given to the patient. So always anybody prescribing a drug, be it a doctor or be it an RMP or anybody, once this reaction is seen, we have to tell them to note the drug and give the patient a card telling that he should avoid this particular drug in future, and alternatives. We have to look for alternatives. Thank you for your patient listening. That's it for today's class.